Hello, welcome to the Clinical Liver Diseases video series. CLD is an official digital learning publication of the ASLD. I'm James Esteban, Assistant Professor of Medicine at the Medical College of Wisconsin and author of Beyond Milan. Liver transplant is the preferred treatment for unresectable hepatocellular carcinoma, especially if there is underlying cirrhosis and portal hypertension, because it can address the cancer and liver disease at the same time. Patients with one tumor less than or equal to 5 centimeters or 2 to 3 tumors less than or equal to 3 centimeters each and without extrahepatic or vascular tumor invasion have good outcomes after transplant. This is known as the Milan criteria, and it has an 83% 4-year recurrence-free survival. Milan criteria are dichotomous and stringent, and thus some patients with larger or more numerous tumors can be deprived of curative liver transplant. To improve access to liver transplant and benefit a greater number of patients, expanded transplant criteria were proposed, which allow for a modest increase in tumor size and number beyond Milan, sometimes in combination with markers of tumor biology, such as alpha-fetoprotein. Some examples of these expanded criteria include UCSF and up to 7 criteria, French AFP and Metro ticket models, and the New York California score. These are shown in the table, and as we can see, patient outcomes after transplant are comparable to Milan criteria. That these transplant outcomes are comparable to Milan is important because for transplant to benefit the greatest number of patients, the outcomes and access to transplant of other patients in the waitlist should not be compromised. Downstaging is another approach to improve access to liver transplant and refers to the use of locoregional therapies such as transarterial chemoembolization, yttrium-90 radioembolization, and thermal or chemical ablation to reduce tumor burden so that HCC satisfies Milan criteria. The ASLD does not make a recommendation on the optimal form of locoregional therapy for downstaging. In 2017, the United Network for Organ Sharing adopted UCSF downstaging criteria used in Region 5 as the standard national downstaging protocol. Downstaging criteria include 1 tumor less than or equal to 8 centimeters, 2 to 3 tumors less than or equal to 5 centimeters each, or 4 to 5 tumors less than or equal to 3 centimeters each. The total tumor diameter cannot exceed 8 centimeters, and there should be no extrahepatic or vascular invasion. Downstaging is successful if the HCC is within Milan after treatment. AFP should ideally be less than 1,000 ng per ml before treatment. If AFP is greater than 1,000 ng per ml, it should fall to less than 500 mg per ml after locoregional therapy. Successfully downstaged patients according to these criteria may receive MELD exemption points. The 3-year survival of transplant recipients who were downstaged according to these criteria at around 80% is comparable to transplant recipients with HCC that never exceeded Milan criteria to begin with. On behalf of all of us on the CLD team, I hope you found this presentation useful. For more information about expanded and downstaging transplant criteria for hepatocellular carcinoma, please visit us at www.cldlearning.com. Thanks for watching.